Now, let us proceed to the part 2 of pre-transfusion testing. The objectives are the same with the pre-transfusion testing part 1. So let me skip this slide. The focus of antibody detection methods is on irregular or unexpected antibodies. Opposing doon sa ABO system kasi expected na yung antibodies na hinahanap natin. So again, here in antibody detection, we are looking for the unexpected antibodies. The first category of unexpected antibodies is the immune alloantibodies. So these are produced in response to RBC stimulation through transfusion, transplantation, or pregnancy. Next is the naturally occurring alloantibodies. So these antibodies form as a result of exposure to environmental sources such as pollen, fungus, and bacteria, which have structures similar to some RBC antigens. The third category of unexpected antibodies is the passively acquired antibodies. So these antibodies are produced in one individual and then transmitted to another individual via plasma containing blood components or derivatives, such as intravenous immunoglobulin. The fourth category of unexpected antibodies is the autoantibodies. So these antibodies are directed against antigens expressed on one's own RBC and generally react with all RBCs tested. So these four categories may complicate the detection and identification of the clinically significant alloantibodies. So clinically significant alloantibodies are those that cause decreased survival of RBCs possessing the target antigen. These antibodies are typically IgG and react best at 37 degrees Celsius or at antiglobulin phase. Antibody detection or antibody screening is critical in pre-transfusion compatibility testing. So it is one of the principal tools for investigating potential hemolytic transfusion reactions and immune hemolytic anemias. So it also aids the detecting and monitoring patients who are at risk of delivering infants with hemolytic disease of the fetus and newborn. Indirect antiglobulin test tube method is the traditional method to detect clinically significant antibodies. So in this method, first, mix 2 drops of patient plasma and 1 drop of screen cell reagent in the test tube. Centrifuge the test tube, and after centrifugation, observe for hemolysis and agglutination. So this phase is the immediate spin phase. In immediate spin phase, cold alloantibodies may be detected. If there are no hemolysis and agglutination, we will proceed to the next step. Add enhancement reagent to the test tube. Enhancement reagent may be added prior to incubation to increase the degree of sensitization. So, after adding the enhancement reagent, you will incubate the test tube at 37 degrees Celsius. So, this phase is the 37 degrees Celsius phase or the thermo phase. In thermo phase, If present, IgG antibodies will synthesize any reagent RBCs that possesses the target antigen. After incubation, centrifuge the test tube, and then after centrifugation, observe for hemolysis and agglutination. If so, to observe for hemolysis, tubes should be carefully removed from the centrifuge. Dapat hindi madidislodge yung button. Check the supernatant for pink or red discoloration. For agglutination, gently dislodge the cell button and read the reaction. So if there are no hemolysis and agglutination, we will proceed to the next step, which is washing 3 to 4 times with normal saline solution. So in this step, unbound antigens will be, unbound antibodies will be removed. Now let us proceed to the AHG phase. In AHG phase, we will add 2 drops AHG reagent. So sensitize RBCs cross-linked by antibodies in the AHG reagent. So after addition of AHG reagent, centrifuge the test tube, and then after centrifugation, observe for hemolysis and agglutination. All negative tests must have Coombs control cells or check cells added to confirm the validity of the negative result. So if there are no hemolysis or agglutination, Coombs check cell should be added to confirm the validity of the negative result. So add Coombs check cells in the test tube and then centrifuge it and check for agglutination. So if there is agglutination, then this will confirm that your negative result is valid. Antibody screening uses RBC reagents or screen cells to detect clinically significant antibodies. So this is a picture of our RBC reagents or screen cells. This figure is the antigen profile of 3-cell screen test. So these are the reagent screen cells, and these are the antigens. Antigens in the screen cell panel have homozygous and heterozygous expression. A cell with homozygous antigen expression is from the individual who inherited only one allele at a given genetic locus. Therefore, the cell surface has a double dose of that antigen. Heterozygous expression is from an individual who inherited 2 different alleles at a given genetic locus. So, in heterozygous expression, the alleles share the available antigen sites on the cell surface. So, these are the common blood group system with antibodies that exhibit dosage, the RH, except D, KID, Duffy, MNSS, and Lutheran blood groups. Table 10.1 are examples of RBC phenotypes from homozygous and heterozygous individuals. So let us take a look. So the phenotype JKA-B positive, A negative B positive. So the antigens present is JKB only. So meaning it is a homozygous. Next is the JK, A positive, B positive. So, meron siyang JKA and JKB. So, meaning heterozygous siya. Then, another phenotype, FY, A positive, B negative. So, meron lang siyang FYA only. So, homozygous. FYA positive, B positive. So, this phenotype have both FYA and FYB. So, heterozygous ito na phenotype. Next is the M positive and negative. So, meron lang siyang M antigen present. So, it is homozygous. Next is the M positive and positive. So, it have this phenotype have both M and N antigens. So, it is heterozygous. Enhancement reagents or potentiators may be added prior to the thermophase to increase sensitivity. Addition of potentiators may decrease the incubation time. So example, instead of 30 minutes, nagiging 15 minutes na lang. So these are your enhancement reagents. The 22% bovine serum albumin, the low ionic strength solution or LISS, and the polyethylene glycol or the PEG. So there are two kinds of AHG reagent. First is the monospecific AHG reagent. This reagent contains only one antibody specificity. So it's either an anti-IgG or antibodies to complement components like C3, C4, C3b, or C3d. Like what I said on the previous slide, any test tube test having a negative reaction after the addition of AHG reagent should be added with Coombs check cells. This reagent contains RBC coated with IgG. These cells will react to the AHG reagent, giving a visible agglutination. The purpose of adding the Coombs check cells reagent is to prove that washing of cells was performed before AHG was added. Second, the AHG was added to the test tube. And third, the AHG reagent is working properly. If the Coombs check cells fail to agglutinate, the procedure should be repeated from the beginning. So there are also other methods in antibody screening, which are the gel and solid phase technology. And this was discussed already on the part 1 of pre-transfusion testing. To interpret results, first, know in what phase did the reaction occur. So the question will be, in what phase did the reaction occur? Most IgM class antibodies react best at room temperature or immediate spin phase. And then the IgG class antibodies react best at AHG phase. Second is to check if there are reaction in the autologous control. So question, is the autologous control negative or positive? Autologous control is patient's RBC tested with the patient's serum or plasma. A positive reaction indicates that the patient have autoantibodies. Third is, did more than one screen cell sample react? So more than one screen cell may be positive when 1. A patient has multiple antibodies. 2. the target antigen of an antibody is found in more than one screen cell, and 3, a patient's serum contains autoantibody. Next question is, if so, did they react at the same strength and phase or phases? So a single antibody is suspected when all screen cells having a positive reaction react at the same phase and strength. Then multiple antibodies is suspected if they react at different phase and different strength. Fourth question is hemolysis or mixed field agglutination present? So there are antibodies that cause hemolysis like anti-LEA, anti-LEB, anti-P, P1PK, and anti-BEL. Lutheran antibodies and anti-SDA causes mixed field agglutination. Number 5 is, are the cells truly agglutinated? So rouleau formation is not a significant finding, but it may mask the true antibody-mediated agglutination. So this happens when a serum of patients with multiple myeloma, there will be a rouleau formation. Again, serum patients with multiple myeloma may cause rouleau formation. So in order to differentiate rouleau formation from a true agglutination, we should know the characteristics of rouleau formation. Number 1, in rouleau formation, cells appear to be a stack of coins. Number 2, it is observed in all tests containing the patient's serum. Number 3, it does not interfere AHG phase because of the washing step prior to addition of AHG reagent. And number 4, it disperses when added with 1 to 3 drops of saline in tube method. Now, let us try to interpret figure 10.4. So here, the first one is has a negative reaction in all phases. Next is it has a 2+ reaction in the AHG phase, and the autocontrol has no reaction. So with these reactions, the possible interpretation is there is a single alloantibody or 2 alloantibodies, antigens only present on cell number 2. Okay, so maybe 2 antibodies per present lang dito sa cell number 2, and 3 probably IgG alloantibody because 2+. So alloantibody siya kasi yung autocontrol natin is negative. So walang autoantibody. Next case is the screen cell 1 has a negative reaction in immediate spin phase, but have a 1+ reaction at the thermal phase and 3+ reaction at the AHG phase. In screen cell number 2, negative immediate spin and 37 degrees Celsius, but 1+ yung AHG phase natin. While yung autocontrol is all negative. So, hindi siya autoantibody kasi negative yung autocontrol. So, the possible interpretation, multiple alloantibodies since may reaction sa 37-degree phase and sa AHG phase. Number two, pwede siyang maging single alloantibody that may show dosage. And number three, probably IgG alloantibody to because ito kasi nag-react siya sa thermo and sa AHG phase. In the third case, the screen cell number 1 has a 1 plus screen cell number 1 and 2 has 1 plus and 2 plus reaction in immediate spin phase, while the other phases are negative. Our autocontrol is also negative in all phases. So the possible interpretation is pwede siyang single or multiple antibodies because of nag-react siya sa dalawang screen cell. And probably, IgM alloantibody kasi sa immediate spin siya nag-react. So, hindi siya autoantibody because negative yung autocontrol. Our fourth case is, it shows that there is in screen cell number 1, there is a 2 plus reaction at immediate spin phase, negative at 37, and 1 plus at AHG. Screen cell number 2 shows 3 plus reaction in immediate spin phase, 1 plus in 37 degrees Celsius, and 2 plus at AHG phase. Our autocontrol is all negative, so walang autoantibody. So we will suspect it is an alloantibody. So possible interpretation of this reaction is that it may contain multiple alloantibodies, warm and cold, kasi may reaction sa lahat ng phases. And then, it may be a potent cold alloantibody binding complement in the AHG phase. There is a complement because ang ginamit na reagent dito is the polyspecific AHG reagent. Our fifth case shows that in the screen cell number 1 and 2, there is a 1 plus reaction in the AHG phase. And then, negative sa lahat ng phases. And then, autocontrol is negative in all phases. So, the possible interpretation of this case is that there is a single warm alloantibody antigen present in both cells. So, itong antibody na to may be a high prevalence. This antibody may be an antibody to a high prevalence antigen, and it may be a complement binding by a cold alloantibody not detected at immediate spin phase. Our last case shows a 3 plus reaction in screen cell 1, screen cell 2, and in our autocontrol. So, ibig sabihin, meron tayong autoantibody. Dahil sa AHG siya nag-react, warm autoantibody ito siya. So, possible din na warm alloantibodies kasi nag-react din siya dito sa screen cell 1 and screen cell 2. And this is also a transfusion, may cause transfusion reaction kasi 3 plus yung reaction. And then, probably, it is an IgG alloantibody kasi, again, nag-react sa on the AHG phase. Lahat may reaction sa AHG phase. So, it's probably an IgG alloantibody. Antibody detection or antibody screening has limitations. So, its limitation is number 1, the screen will not detect antibodies when the antibody titer has dropped below the level of sensitivity for the screening method employed. Second, the screen cannot detect the antibodies against low-incidence antigen. And third, the antibodies showing dosage may not be detected if none of the screen cells have homozygous expression of the target antigen. After the detection or the screening of antibodies, we will proceed to the antibody identification. So antibody identification is to identify the antibody and determine its clinical significance. The first step in antibody identification is the patient's history. So the health history of the patient is important because this provides clues for antibody identification. For example, if you know the race of the patient, like anti-U is associated with the African individuals. Another examples, in patient history, you will know if the patient have multiple transfusion or if she is pregnant. Next is the reagents. The antibody identification panel, the second picture, has the I sorry the antibody identification panel is a collection of 11 to 20 group O reagent RBCs. So the profile sheet for antibody identification can indicate the presence of rare cells, low or high incidence antigens, unlike in the antibody screening. The second step will be the second step in antibody identification is to exclude or rule out antibodies that could not be responsible for the reactivity seen. So we will have the exclusion. I will show you later on. And then we will have our evaluation of panel results. In the figure, you will notice that the check cells have a 3+ reaction here. The check cells have a 3+ reaction in all cell panel that have a negative reaction in all cases here. So, meaning these tests were done properly. Next, let us take a look at the autocontrol. The autocontrol shows negative reaction in all cases, meaning there are no antibodies. So the questions here in the left of the slide will help us identify the antibody we are looking for. Question number 1. Do all the positive cells react at the same degree? So the strength of the reaction will indicate the amount of antibody we are looking for. A stronger reaction may show dosage. Different reaction strength indicate more than one antibody and antigen with variable expression. So in this figure, you will notice that the reaction strengths are 2+ and 3+. So multiple antibodies or single antibody showing dosage is considered. Number 2, do all the positive cells react at the same phase, or do any react at different or multiple phases? Different cells reacting in one phase and different cells reacting at another phase will indicate multiple antibodies. Cells reacting at multiple phases may also indicate antibodies showing dosage. The phase of reactivity will also help us indicate the clinical significance of the antibody because IgM antibodies usually react at immediate spin phase and IgG antibodies react at AHG phase. So in the figure, you will see that there is a reaction in the AHG phase. So you will consider that this antibody is IgG. Number 3, does the serum reactivity match any of the specificities? When a single antibody is present, the pattern of activity usually matches a pattern of antigen expression. So here in the figure, it matches the FYA pattern. So we will see. Now, we will do ruling out. We will rule out the RBCs that gave a negative reaction in all the phases because maybe these antigens are not the target of the antibody. So in cell number 2, we will exclude, since negative ito, yung phases natin, so we will exclude lahat ng nag-positive, lahat ng may positive na reaction. So, we will exclude D, large C, small e, CW, okay, we will not exclude Shalano because this shows dosage. Next is KPD, JSP, FYD, JKA, P1, M, S, Lutheran B, and XGA. In cell number 5, we could exclude C, already excluded, we will not exclude the small c because it shows dosage. Then next E, so we can completely exclude small e. Then K here, so we could exclude Shalano because it is not um, it does not show dosage here, so we will exclude it. Next, KPB already excluded, JSB already done, JKB we will exclude JKB. LEB excluded ng P1, M, S, then small s, we will not exclude small s because it shows dosage here. And then Lutheran B excluded already. Now in cell number 8, so we could exclude small letter C because it does not show dosage here. Completely exclude na. Next, already excluded na small e. Yep. KPB already excluded. JSB, FYB, done. Okay, done. So here, LEA. So LEA, we will exclude LEA. Next, done. Done. Lutheran B and XGA, done. Next, panel number 9. Panel number 9. So, excluded na. Yes. And then the large E. So we will not exclude large E here because it shows dosage with the small e. Next, excluded, done, already done, FYB done, JSA done, LEA, P1, M, S, Neutralization. Here pala. Pwede natin exclude si small s. Okay. Check natin ulit. We could also exclude M. Kaya guys, kailangan talaga natin ng ruler nito para hindi kayo confused. So we are done with the cells that have no reaction in all cases. So let us proceed doon sa mga may reaction sa AHG phase. Question number 4. Are all commonly encountered RBC antibodies excluded? So, ang naiwan ay yung E, KPA, JSA, FYA, and your Lutheran A. So, after exclusion, we will proceed to inclusion. In this step, we will look into the panel cells that have a reaction in the IAT phase. So, IAT phases rather. since may positive reaction sa AHG phase, tatanggalin natin yung mga cells na may negative reaction. So, kanina yung positive reaction ang in-exclude natin. Ngayon, yung negative reactions naman ang tatanggalin natin. So, first, cell number 1. So, again, yung negative reaction, yung i-exclude natin. So, here, letter E. So, may zero reaction. So, we will exclude E. And then, KTA. JSA. And Lutheran. So, at this point, ang naiwan na lang is yung FYA. For the fifth question, I have mentioned about this earlier already. So let us skip to this number 6 question. So number 6, is there enough evidence to prove the suspected antibody? So which is FYA. So as you can see here, in all the remaining cell numbers, makikita natin na FYA is positive. So lahat ng cell number that matches our reaction here in the AHG phase. So, if mapapansin nyo, if we highlight also this one, these negative reactions, so mapapansin nyo, sorry, let me erase that. So, mapapansin nyo, ito dito, the panel for FYA matches the reactions here in the AHG. So, tingnan nyo, for example, this one, 2 plus. So, may plus tayo dito, FYA. Negative dito, so negative din sa FYA. So, positive, positive. So, as you can see, we have more than enough evidence. Number 7, does the patient lack the antigen corresponding to the antibody? So, the last step is to test so since we identified our antibody, so the last step is to test the patient's RBCs for the corresponding antigen. So, this will be our confirmation kung meron ba talagang ganitong antigen si patient or wala. So, ang result dapat is negative ang cells ng patient with FYA kasi nagkaroon siya ng antibody against it. So, if the patient's RBC are positive for the corresponding antigen, baka may misidentification or false positive, I think. So, this is how you will evaluate your panel screen, your sample panel, your panel rather. So, this is how you will identify the antibody. Additional techniques for resolving antibody identification. First is the selected cell panels. Testing additional cells from different panel or panels is the simplest step to take. The cells that you will select should have minimal overlap in the antigens they possess. The first set of panel result is the initial one. This one, the first set is the initial one, initial panel results. And then the panel result below is the selected cell panel. So in the selected cell panel, you have the reagents R1, R1, small r, R2, R2. Selected cell panels is useful when a patient has known antibody and the medtech is attempting to determine additional antibodies present. Next is the enzymes. So proteolytic enzymes modify the RBC surface, resulting to destruction of certain antigen. So enzyme-treated panel will aid in identification when there are multiple antibodies. Enzymes may took place the enhancement media. In table 10.3, proteolytic enzymes will enhance the RH, KID, Lewis, E1I, and ABO antigens, and they will inactivate Duffy, MNS, and XGA. So this is an example of enzyme panel. So as you can see, AHG is added with piscine. While here is your enhancement media, PEG. Dito is your enzyme, piscine. Neutralization. So there are substances that can neutralize antibodies. Neutralization allows exclusion of remaining antibodies or confirms the presence of an antibody. To perform neutralization, first incubate the patient's serum with a neutralizing agent, and then second, perform antibody identification panel. So in table 4, this will show the sources of substances for neutralization of certain antibodies. So for example, anti-P1, yung source niya for neutralizing a substance is the hydatid cyst fluid, pigeon droppings, turtle doves, egg whites. Anti-Lewis naman, plasma or serum or saliva. Anti-Chido or anti-Rogers, the serum, which contains complement. Anti-SDA, our urine. And then anti-I, the human breast milk. In performing neutralization, using a control is required. The control is saline mixed with the serum. The purpose of having a control is to prove that the loss of reactivity is due to neutralization and not the dilution of the antibody to the added substance. In this panel of result, you will observe that based on the reactions, you will observe that the possible antibodies present will be the Kel and the Lewis B. But after the neutralization, here, after neutralization, the reaction matches the Kel antigen. So, possibility, there is the anti-K. Next is adsorption. So adsorption is where particles stick to another surface. So like the illustration shows, So this is absorption, and adsorption is particles stick to another surface. In this technique, an adsorbent, which are the RBCs, are added and incubated with the serum or plasma to remove or adsorb antibodies. Then the antigen-antibody complex will form a solid precipitate, and the precipitate will be separated through centrifugation. And then, the adsorbed plasma or serum can be tested against RBC panel cells. There are types of RBC adsorption. So first is the autoadsorption, allogenic adsorption, phenotypically matched adsorption, and the differential adsorption. So when there is presence of autoantibodies, RBC adsorption is used to detect clinically significant antibodies. Autoadsorption or autologous adsorption is used when the patient has not been transfused within 3 months and his RBC volume is adequate. This method uses patient-owned RBCs as the adsorbent. For the procedure, first wash thoroughly the autologous RBCs to remove unbound antibodies. In this figure, yung autoantibody natin is yung triangle and the alloantibody is the square ones. Next step is treat RBCs to remove autoantibodies coating the RBC. And then, incubate the treated cells with the patient's serum or plasma for 30 to 60 minutes. So, ito na yung adsorption step natin. Incubate in 4 degrees Celsius to remove cold autoantibodies. So, then, 37 degrees Celsius naman to remove warm autoantibodies. So, in this step, we should mix the sample periodically. After incubation, so adsorption is complete. So we could now harvest the serum or plasma and test for DAT negative autologous cells. If the DAT shows a positive reaction, do further adsorption using new alico of autologous cells. If negative naman, proceed to antibody identification testing. In figure 1012, sorry. In figure 1012, in the column in the PAG-IgG panel, the reaction shows 2+ and 3+ reactions. And there is also a 2+ reaction in our autocontrol. So maybe there are multiple antibodies in the serum and an autoantibody. So after doing adsorption, this one, after doing adsorption, you will see that the reaction matches the K panel. So tingnan natin. So K, negative, negative. There is a 2+ reaction here. Plus, negative, negative, negative. And then plus, 2+, and then again, negative, negative, negative. And plus, 2+, and lastly, negative. So they have the same reaction. So the antibody present is anti-K. Allogenic adsorption is used when a patient has been recently transfused. This technique is the removal of alloantibodies using allogenic RBC adsorption. This technique is used when number one, there is a previously identified high prevalence antibody present, and number two, when multiple common alloantibodies have been previously identified and are thought to be present. Phenotypically matched adsorption can be used when the phenotype of the patient is already known, or when or the patient is not transfused within 3 months and the AT is negative. So for example, if the patient is known as K negative, then he may have the anti-K. Differential adsorption is performed when a patient's phenotype is unknown. So baliktad siya doon sa phenotypically matched adsorption. So again, differential adsorption is performed when the patient's phenotype is unknown, recently transfused, and positive in DAT. So there is another example in resolving antibody uh, uh, identification. So it is the alteration in pH because most antibodies react best in neutral pH, which are 6.8 to 7.2, but some react at 6.5. So like anti-M, which reacts at 6.5 pH. So acidifying the test system will help identify anti-M. Direct antiglobulin test is valuable when investigating suspected HDR, HDFN, autoimmune or drug-induced hemolytic anemia. DAT is used to detect in vivo sensitization of RBCs. After cells are thoroughly washed, AHG reagent is added. Then centrifuge and observe for agglutination. Absence of agglutination needs to be added with Coombs check cells to validate the negative result. Presence of agglutination indicates presence of in vivo sensitized RBCs. So positive DAT will proceed to the next step, which is elution. Elution test aids the diagnosis of autoimmune hemolytic anemia, ABO hemolytic disease of the newborn, identification of specificity when multiple antibodies exist in a patient's serum or plasma, and phenotyping red cells in patients with a positive DAT. Elution tests dissociate or free the antibodies from the red blood cell surface to allow identification. So here, elution free the antibody. The methods used to free the antibodies are 1. Change in the thermodynamics of the environment. 2nd, change in the attractive forces between antigen and antibody. And 3rd, change the RBC surface structure. These changes may be achieved through heat, cold temperature, or acid. The resulting solution of elution is called eluate, which then can be tested in the RBC panel to identify the antibodies present. After identifying the antibody, it is useful to do antibody titration to quantify the amount or concentration of the antibodies present. Antibody titration could be done using flow cytometry, radioimmunoassay, or enzyme-linked immunoassay. But these techniques are not available in some laboratories. So instead of doing those techniques, pwede natin gamitin ang twofold serial dilution. The titer level is reciprocal of the greatest dilution in which agglutination of 1 plus or greater is observed. Previous and current sample should be compared because a 10 or more increase in the score or fourfold increase in the titer is considered clinically significant. So for example here, table 10.5. So as you can see, the previous sample have a titer of 8 and its score is 21. So to get the score, we will add all the scores. So 8 plus 8 plus 5 equals to 21. That's for the previous sample. Next, for the current sample, the titer is 32 here. So 32. And the score is 41. So comparing the two, meron tayong fourfold increase sa titer natin and the score has an increase of more than 10. So meaning, we will consider that there is a clinically significant antibody present. So class, that's all for my lesson for the pre-transfusion testing. So my references are the following. Thank you, class, for your time and for listening. I will leave you this verse, Philippians 4:6. Do not be anxious about anything, but in every situation, by prayer and petition, with thanksgiving, present your requests to God. Thank you again and God bless.